Usual interstitial pneumonia. This was previously known as cryptogenic fibrosing alveolitis. Etiology. Not known, but it is more common in cigarette smokers. Pathology. For many years the gold standard for diagnosis of cryptogenic fibrosing alveolitis was histopathological evidence from lung biopsy, which in the majority of cases shows features of usual interstitial pneumonia, UIP. With developments in high-resolution CT scanning, which can diagnose UIP with a high degree of certainty, lung biopsy is now indicated only when diagnostic doubt remains after radiological assessment. When a tissue diagnosis is required, video-assisted thoracoscopic lung biopsy or open lung biopsy is necessary, as transbronchial biopsy does not usually provide an adequate sample to make a confident diagnosis of UIP. Epidemiology. Most patients are between 40 and 70 years of age at the time of presentation. The incidence of UIP increases with age from 2.7 per 100,000 among adults aged 35-44 years old to 175 per 100,000 among those over 75 years old. Clinical presentation. Insidious onset of breathlessness, often with a dry cough and fatigue. Sputum production is unusual. Hemoptysis is uncommon and suggests malignancy, see below. Physical signs. Bibacillar late-onset inspiratory crackles, these may be present in the absence of radiographic abnormalities on the CXR. Finger clubbing occurs in 50% of cases. Look for non-pulmonary features that would suggest alternative diagnoses, e.g. skin rashes, arthritis, or lymphadenopathy. Investigations. Pulmonary function tests. Look for restrictive pattern and/or decreased diffusing capacity of the lung for carbon monoxide, DLCO. As a high proportion of patients with UIP are smokers, in practice a mixed restrictive and obstructive pattern may be present. Chest radiograph. Check for peripheral bilateral basilar irregular linear opacities, often with fine nodules, evidence of volume loss and, in severe cases, honeycombing. In the small proportion of cases subsequently shown to have UIP, the CXR may be normal. High-resolution CT scan of the chest. Look for peripheral and basal subpleural distribution, honeycombing, irregular linear opacities, septal and intralobular thickening, minimal ground glass opacities and traction bronchiectasis. Arterial blood gases. These may be normal at rest, or may reveal hyposemia and respiratory alkalosis. Normal resting PaO2 or SaO2 does not rule out significant hyposemia during exercise or sleep, which is common in DPLD. Differential diagnosis. UIP is a diagnosis of exclusion. Other known causes that may show similar high-resolution CT appearances to UIP must be excluded, such as asbestosis, drug reaction, chronic hypersensitivity pneumonia, chronic sarcoidosis, and cryptogenic organizing pneumonia. Treatment. There have been no prospective, placebo-controlled, randomized trials. Only a minority respond to treatment, and the pros and cons of immunosuppressive therapy should be discussed with each patient. Options for treatment include the following. First-line treatment, oral prednisolone 0.5 mg/kg with or without azathioprine, 2-3 mg/kg daily, with reassessment at 1 month. In severely ill patients, intravenous methylprednisolone may be used. A response, 1-3 months, or stability should be followed by a slow tapering of prednisolone to a maintenance dose of 10 mg daily for 1 year. A further slow reduction may be considered subsequently. Objective response rates are poor. Second-line treatment, cyclophosphamide, 1-2 mg/kg, if azathioprine is not tolerated. Single lung transplantation, for end-stage disease. Palliative treatment, oxygen, diuretics, and opiates. Complications: COR pulmonal and respiratory failure. Tenfold increased risk of lung polyganky. Prognosis: poor, median survival is 3 years, 10-year survival rate is 5–10%.